Devi, a 32-year-old female, homemaker and farmer by occupation, hailing from North Karnataka, came with chief complaints of breathlessness for the past 2 years. History of presenting illness. The patient was apparently normal 2 years back, after which the patient developed dyspnea on exertion, initially while climbing for 2 to 3 flights of stairs or walking on an uphill, gradually progressed, and now for the past 15 days have breathlessness on rest, increase on lying down, improved with medications. Patient also gives history of cough with more expectoration associated with running nose and sore throat around 3 to 4 times per year for the past 2 years. During the episode, patient had increase in severity of breathlessness, like walking to restroom, the patient will have breathlessness. Patient used to go to a local doctor, and patient used to symptoms include on medications, and patient goes back to a routine life. There is no history suggestive of paroxysmal nocturnal dyspnea. There is no history of palpitation. There is no history of chest pain. There is no history of blood in sputum. There is no history of wheezing. There is no history of loss of consciousness or giddiness. No history of fullness of legs or body. No history of decreased urine output. No history of weakness of the body, or no history of redness in the skin. No history of joint pains. No history of fever. Past history and treatment history. Patient used to get treatment for the cough, running nose and sore throat in local hospital on OPD basis, was given oral medications and IV drugs. Patient was told to have lung disease for the past 2 years. However, during her last episode, patient's symptoms did not improve, and when she got treated 15 days back, patient was referred to higher hospital where she was diagnosed to have cardiac disease and was given medication. Patient gives history of increased passage of urine when she was treated recently in the past 15 days. There is no history of diabetes mellitus, there is no history of hypertension, no history of thyroid disorder, no history of regular medications, no history suggestive of penicillin prophylaxis. Family history. Grandmother had cardiac surgery, details not known. Father died around the age of 50 due to cardiac disease. The father was quite ill for 2-3 days, was taken to the local hospital where she was diagnosed, where he was told to put a stent, but he was taken to ICU, later he died actually. Personal history. Patient has a vegetarian diet, sleep normal, normal bowel and bladder habits, has 2 kids, 1 daughter and 1 son, both are in good health. Menstrual and obstetric history, normal menstrual cycle, bleeding on 3 for 28 days, 2 deliveries are done through normal vaginal delivery, no peripartum complications. Summary, 32-year-old female gives complaints of breathlessness. Initially it was NYHA class 2, progressed to NYHA class 4 for the past 15 days. Patient also gives history of recurrent episodes of cough with running nose. During the episode, patient breathlessness worsens, which improves on taking medications. However, patient symptoms did not improve for the past 15 days, referred for higher center where she was improved with medications and came here for further management.
What do you think?
My provisional different diagnosis are left side stenotic lesion, probably mitral stenosis, congenital heart disease, ASD, anemia.
Let us stick to the first one, not other duration, right? So you 32 years, symptomatic for last 2 years. What do you think of what kind of left side obstructive and severity?
Sir, considering her age, it's probably mitral stenosis.
32 years, symptomatic only for 15 days. Normally at the age which is progressing very rapidly.
So usually not, sir. Usually it takes around 2 decades after the episode of an rheumatic fever for the disease to obtain clear. But in 20% of cases it can be rapidly progressive at present age.
The sore throat history is only for 2 years or before it was there?
So she gives conclusively for 2 years only. So before here also she had some for around 6 months, 1 episode. But conclusively she gives around 2 years and having regular sore throat conditions.
Also again not the age for 2 years, 32 minus 2, not a very common age to get sore. And there is no history of penicillin. Because she has normal deliveries, 2 deliveries. So that is against your theory of left-sided stenotic lesion mitral stenosis. How can somebody will have 2 normal deliveries? Vaginal, hospital, home?
Sir, one was on the way to hospital, sir. One was hospital.
So normal delivery. Assume that one is at home, another is at hospital. So patient tolerating 2 deliveries, pregnancies, He is bringing just because he has breathlessness and sore throat.
Delivery was around 11 years back. 2012 was the first check. 2013 was the second check.
So 1 year gap.
1 year yes.
That may even bring, suppose the patient will have a rheumatic heart disease, maybe initial to start with mild regurgitant lesion, then patient had subsequent pregnancy, uneven non-symptomatic. I will not bring a stenotic lesion first, maybe a regurgitant lesion, which is tolerated in initial pregnancy. Now, to bring a stenotic lesion, why say symptomatic for last 2 years, what she was doing for 30 years? -5. But the source rate is 5 to 15 years. Then second, she becomes symptomatic for 2 years sore throat, not symptoms related to heart disease. Heart disease, as per your statement, 15 years.
She was resistant on anxiety. Yes.
What NYHA 2?
Initially it was NYHA 2, sir.
Now progressed to 4, 15 days. So all the duration is 15 days. So 15 days, why is she deteriorating? So precipitated by infection. Possibility, can she go into atrial fibrillation?
So that's a possibility.
Possibility. So he's gone into rhythm disorders, he's gone into respiratory infection, lungs infection. So it can precipitate. Otherwise, recurrent rheumatic activity. But you said there is no joint pain now. So recurrent rheumatic activity is gone. So what is a endocarditis? No. There is no prolonged history of fever. So this could have a respiratory infection which triggered this previous history, making her symptomatic for 15 days. And in the history you mentioned symptomatic, she got some medication which made her to pass a lot of urine. So that means diuretics has been given. So that means last 15 days patient has gone into failure. NYHA class 4. So it has gone into failure. But you said there is no PN.
Yes, sir.
How can it be patient requiring diuretics and passing a lot of urine? So that means treatment is wrong.
We had orthopnea, but she doesn't use for PNE.
So if there is no PN, less likely you are dealing with mitral stenosis. Less likely. And if mitral stenosis is gone into heart failure, NYHA class for requiring diuretics and feeling better with the treatment of diuretics, usually there are people. So all practical purposes looking from the theory, 2 pregnancies uneventful. I think of rheumatic heart disease, maybe regurgitant pregnancy, tolerated well pregnancy. If at all you have to bring mitral stenosis, it is very mild. Moderate severe mitral stenosis will become much more symptomatic. And I will bring whatever the lesion underlying rheumatic heart disease got exacerbated because of the respiratory infection. That is my history there. Not AST, not anemia. Anemia, you said delivery was 2014 or 31, 32. So now it is 23. So 10 years. So anemia cannot explain. That is out. ASD to breathlessness, no palpitation you gave, there is no fatigue, tiredness. So that is again not in my favor. The rheumatic heart disease, regurgitant lesions, repeated sore throat, symptomatic because of the respiratory infection. That I will get derived from this. Okay, fine. Not serious, not serious. Here 2 uneventful deliveries. On the way to hospital she delivered. But that means the hemodynamic will not be seen. See, let's go to the findings.
General examination. Patient is alert, conscious, oriented to time, place, person. Respiratory rate was 70 per minute. Pulse rate was 72 per minute. Rhythm normal, volume normal, character normal, no radial or radio-femoral delay. Felt in all peripheral areas. BP in right upper limb 100 by 80, left upper limb 104 by 76, right lower limb 98 by 72, and left lower limb 108 by 76. Neck veins not distended. Icterus clubbing cyanosis, ileedema and lipidinopathy negative. Temperature normal.
Body temperature.
Around 36 to 35.
Huh?
36 to 35.
98.9 to 99.9.
I'm not asking
Aortic examination, paper is just normal. cardiac normal. Epic impulse not visible. No other visible pulsations. No scars. No sinuses. Palpation. Apex lead is located in the fifth intercostal space, 1 centimeter medial to midclavicular line, tapping in nature. Grade 2 parasternal heave noted. No thrill observed. Noted. Auscultation. S1 loud, S2 normal split with respiration, and A2 normal, B2 loud, opening snap present, low pitched mid-diastolic murmur heard in the apex, with the patient in the left lateral position with the bell of the stethoscope, with patient holding breath in expiration with pre-systolic accentuations. There is no radiation of.
Hang on. Anything anybody wants to add here? In this description, anybody wants to add anything?
Just like rumble.
You mentioned anything? Huh? Louder, louder. Anything you want to add? S1 loud, S2 normal speed, A2 normal, P2 loud, is it just right? S4, okay, additional sounds in option there. See? You have to mention additional sounds are an option. Anything else? Huh?
Gap between E2 and
Normal respiratory variation of the spleen. It is mentioned normal spleen. It is understood that it is a normal respiratory variation. Anything else? Anything else? What else I am looking at here? That he is talking about mitral stenosis, right? Loud first sound, P2 loud, opening snap, and the murmur, left lateral position, breath, hurling breath, expression, pre-shift reaction, mid-diastolic murmur, out, and no radiation. So I got an idea that he is talking about mitral stenosis, but I have no idea what is the severity. A2OS gap. You have to mention A2OS gap. Length of the FDM. Length of the FDM, how much is your plan? Okay. So length, longer the murmur, more severe is the stenosis. Reverse is not true. Suppressed murmur may not roll out seriously. A2OS gap. Gap is wider, it's tighter, or narrower is tighter?
Narrow is inversely proportional to the severity.
So you have to mention. Understood what is lacking there? Fine. So next.
Another system examination, respiratory system. Lateral chest normal vesicular pressure noted. No added sound. Abdomen soft. No organ emulation.
No other additional murmur of the patient? No. Any other things you want to? Neurological system you have to mention. Rough. CNS, NAD or whatever. Cursory examination required. So valvular arteries you cannot get missing mild weaknesses. So back to my stethoscope. Any other reason why they get hemostasis?
Respiratory infections is because of
Yes, one of the respiratory tract infection.
bronchial vein, veins, structure of bronchial veins.
Pulmonary edema hemostasis. You have to say pulmonary edema hemostasis. Mitral bronchitis hemostasis. Pneumonia hemostasis. Somebody is immobile or not mobile. They can have atrial fibrillation and provoking as the last. So the respiratory can have the pleural effusion.
Yes, sir.
Why do you have pleural effusion?
When private failure sets in, patient can have a pleural
We are going to heart failure, like that. So the respiratory manifestations of mitral stenosis. You have to think what are the possible causes of long involvement in valvular heart disease, especially mitral stenosis. Mitral stenosis has some peculiar things like opening snap, snapping first sound. It's called snapping, like snap. Snapping first sound, opening snap. It's called loud and snapping first sound. And with loudness and snapping first sound, it is due to what?
basically sudden.
Only when you feel the effects, how do you feel the effects? In mitral stenosis. Tapping. What do you mean by tapping and why tapping occurs? There is a palpable first sound. So that causes like as if it taps. So first sound is produced where? Right. Let's say atrioventricular valve. And what you are palpating is the apex. So Why it produces that kind of tap? The apex, she said, it is loud first sound. First sound is produced due to the closure of left side area, not T1, M1 we are talking about. So how can you feel that closure near the apex as the tap?
It is because of the sudden closing of the down. The leaflet has to travel a longer distance because of the restricted due to also that
Obviously, you have to say about the vibration. Whatever the explanation for loud first sound, that is there. When you suddenly you are trying to close the valve, loud first sound occurs. The vibration of the first closure sound of the M1 goes to the apex. You palpitate as a tap. It's like a tap. Like that. Okay, that is one. So these are very peculiarity of mitral stenosis. They said malar flux. Why you get malar flux? Why the malar flux occurs in mitral stenosis? What is malar flux?
Malar flux is the movement over the area of just over the nostril and around the side areas.
Why that occurs classical in mitral stenosis? Why not? Why ventral bronchitis occurs in mitral stenosis? Okay, so these are the questions you have to answer. So the mitral stenosis is simple. In the examination you will be in trouble unless you know the details of this. So you have to describe the opening snap. What is that snap? What is the gap between A to OS? What is the why it is not audible? What are the situations where opening snap is not audible but MS is paid?
Calcified mitral stenosis. Presence of associated lesions like MR, AR, vascular CS, any conditions which increases the LVED can decreases the LVED.
Anything else?
Ischemic hypertension in severe cases. So congestive cardiac failure can reduce the
Everybody be wrong. Anything else?
AF.
right heart failure is still actually.
Here you don't get opening snap. Who is selling this?
We usually let it know the severity is not there during the
AF
condition.
becomes
That is
shocks.
different. Who said it? I asked the question, absent opening snap but MS is present. What happened to mixed bleeding? MS and MR where the MR is dominant.
So in MR, the opening snap gets narrower selection. The A2H capital narrower. It is severe. The MR is predominant. Opening snap can be
You may not hear opening snap. If MS, MR is there, MR is dominant. Okay. And mild mitral stenosis. If the valve is less than normal but still more than 2.2 say. What will happen to the opening snap? Is there any murmur in a rheumatic heart disease possible without valvular involvement? There is no valve involved. Is there any murmur possible in a rheumatic heart disease? Without valvular involvement, is there any murmur possible in rheumatic heart? Very difficult question. What is that carry? You don't carry, but is it womb, not a womb. Where the murmur is generated in carry? Anybody? Pericomb's murmur is where it is generated, why it is typical of rheumatic heart disease or rheumatic fever, carditis. Where it is generated, you have to note this. Generation of Pericomb's murmur, rheumatic fever. Okay? And then you go to investigation. Here it is in mitral stenosis, EHCR. Lung participation.
Why do you get loud as well in nasal perfusion party? Can have varying
Yes, sir.
what is the mechanism of cloud starts from atrial fibrillation?
It's saying
in sinus rhythm, intervention classical, and known signs of infective endocarditis. So showing increased pulmonary vascularity in the upper source and as well as in the cardiac wall. That's an enlarged pulmonary vein, enlarged atrial appendage. And the straightening of hot water movements, along with the canal angle is white.
yes. Then lungs.
The lungs, there's non-motor classification operate. Increased vascularity, bronchial vascularity operate more than lateral one-third, in the lateral one-third.
So increase QP. How do you differentiate pulmonary arterial marking versus venous marking?
The venous marking usually upper zones and along with
That is
catering.
what we see.
We are seeing combinations. You are meaning, see, don't confuse it. Increased QP versus increased PA pressure. When there is a pulmonary arterial hypertension, do you think that there is increased flow to the pulmonary artery? Increased flow means you are hitting something else. Yeah, correct. Is there any mitral stenosis or no mitral stenosis? Looking at a straight line or multiple humps? Humps are there. Why is like that?
Because of enlargement of atrial appendage and bronchial.
Is there any right atrial enlargement? You were saying that the pulmonary there more than 2.5.
It's there.
So it is mitralization of the left border half, widening of the carinal
After
angle.
that mitral line,
Yes,
that
yes.
border little bit is there, or another will be. That also.
This is restriction. This is high.
That is LA.
As you can see, it's the above. Yeah, what touches the diaphragm is the R.
Yes. Whatever the enlargement, what touches the diaphragm has to be RA. And while you are putting the finger that's touching the diaphragm, cannot be LA. LA has to be within that. If LA becomes very deep, go outside the lateral border. But the extreme which touches the diaphragm has to be RA. Okay, the LA can go like this. Cover the RA, go outside the RA boundary. Touching the atrium which touches the diaphragm has to be RA. Okay.
Prominent arterial symptoms.
PH, PVH.
The arteries of the prominent.
When you get the mitralization of the left border heart, it's not a real straightening. So what are the other possibilities will come to your mind? It will be like a straight line with mitralization. When it's not real straight. You know why the straightening occurs?
Because the LA enlargement.
Enlargement.
Left atrial appendage.
After that,
Small aortic knuckle along the normal pulmonary vein.
pulmonary vein full,
Full pulmonary.
pulmonary vein full, bit full, and the appendage is enlarged. And then LV is right underfilling of the left mitral stenosis. So these will make a straight line. And if you are not a real getting a straight line, something is one is more, one is lesser.
But
What's
we
suspicious?
not try to in all the enlargements, isn't it? Maybe
Yeah,
like
maybe
this,
like this.
oscillations.
What other possibility do you think of? With MS.
Other valvular lesions.
Okay, so let's see. What I was thinking is, they have already taken that word. MS with ASDs. You cannot find the exact straight line. With ASD we find the more of the pulmonary.
The parasternal long axis view. Showing thickened AML and thickened PML. This is that's an artistic appearance of the AML lesion. Different. The LV this appears normal. LA appears enlarged. Aortic appears normal and aorta from enlarged. RD appears.
That's all. And subvalvular apparatus you see or don't see? You see the sublunar process, sublunar division.
Modifications.
Which one is linked to your hockey stick here? So coming to the LA or going to the LV? Not coming to the LA. Look at this. Which one is hockey stick? Coming to LA or going to LA?
Reverse hockey stick.
This is, you have to learn from him. This is called reverse hockey stick. What is reverse hockey stick? How is the hockey stick? So everything like that. Reverse? Okay. Reverse. From which view you will see the mitral valve will appear your reverse hockey stick. First you tell me systole or diastole?
Hockey stick is diastole. Reverse hockey stick is
Go and read today. What is called bent knee appearance or reverse hockey stick side. Reverse hockey stick or bent knee appearance. You see that?
diastole. Diastole.
Bent knee. Okay. Fine. That's very general. Anything else? Active valve is not seen. But something is seen. So which one is fused? Both or one is fused, one is still open? Lateral is open. Vertical to right side is bad or what? Medial is open at around 10 o'clock position. Lateral is fused. Okay. Next. The flame. What is the flame? The jet flame pattern or multiple jet flame. So what is the description? And is there any flow acceleration? Do you get a piece of flow acceleration proximal to that? And in LA, then you get a mosaic. And what is the description? Wider, narrower, narrower, wider. What is flame effect? You get a multiple speed of the jet description. What is the interpretation? So we read this mitral here. How much is this? What? How severe it is? So which classification you are using? HL like this. So old classification still it is more than 1. 1.03. So by definition in old wise not severe. So now it is less than 1.5 is severe. Less than 1? Now read this pressure of time. So what is it? Bad or good?
Very severe.
Very severe. And this is the flame what I was telling you. If you read, look at the carefully, observe the color flow. You have a red in the helium. That's the flow expression. Then how the jet, which commissure is going? One is fused, right? Then what is narrower, wider? Is it going to the single color flow or multiple? The flame is usually single or multiple? So the thick next. What is this EF slope and DE amplitude here? This pattern resembles like this.
How much slope is there in axis here? Less than 50 millimeter per second. So it is 60 meters.
Okay. If you get this pre-systolic accentuation, what is your interpretation? This spectrum. There is pre-systolic accentuation. What is the interpretation?